Thanks so much. So my name is Nate Kraitman, one of the infectious disease fellows, if you don't know me. So since my wife is pregnant, that was kind of how this kind of started. And then I took our ITE, and it seemed like that was very important to know this as well. So it was kind of a double piggyback. So the first thing that I want to talk about is, I think whenever we get a consult and you hear that the patient is pregnant, you get a little bit of palpitations and you feel nervous. And I think that kind of comes with the stress of you'll potentially be affecting 2 lives. And I think that's, I know that's my feeling. I'm not sure if everybody else has that feeling, but I know that you're going to be affecting 2 lives. The first patient is going to be usually a young lady, and then you're potentially affecting a child for the rest of his or her life. Interestingly, this is from the New England Journal, 2011, by malpractice claims by percentage annually. And you can see that all the surgical specialties are the most litigious, and then GI, which is also an intervention, but then OBGYN is pretty high up there. It's like number 7. So just important to know from that. We probably fall into the really far down, so which is better. But still, anywhere where you're having interventions, you're more likely. But still, I mean, OBGYN, I thought historically is pretty high up. I think the big thing that to take away from this talk is that the trimesters conceptually are really important, and they're divided a little bit differently. So first 1 to 12 is going to be first trimester, 13 to 27, and 28 plus, and I'll show you a slide about what kind of the development of each. Also, the amount of estrogen is going to be really, really high in a pregnant woman, so you're going to produce a lot more protein, specifically albumin. And when you're producing that much protein, you're going to have more albumin, so it's going to bind protein-binding drugs more. So that's going to affect your pathophysiology and the physiology of your drugs. And then you're going to have more blood volume. So again, it's going to affect all of our drugs, their volume distribution, and things like that. So you just have to keep that in mind. As far as development, and going back to the trimesters, if you look here, the black circles are basically which part can be majorly affected at which week of pregnancy. So the first 3 weeks, the 3rd week, you're going to have CNS and heart. The 4th and 5th week, again, eyes, heart, and limbs. But the reason it's important to realize the trimesters is because really, if you go past, I mean, CNS can be affected throughout the whole time, but past 16 weeks, you're much less likely to affect other organ systems. So I think conceptually that's really important to know that really the most harm that we can cause is going to be in the first trimester. So all of our medications and all of our counseling is really important at the beginning. And the reason I bring up counseling is because if you think about it, especially with some of our HIV medications, if somebody's on Bactrim prior to conception because they're on PJP prophylaxis or something like that, you have to be cognizant of that because they're not going to realize they're pregnant until week like 8, and by then, if you would have caused damage, you would have already likely caused the problem. So I think that's really important to know. And along the same lines of the kind of harms and risks and things like that with all medications, I think we're all familiar with the 1979 introduction from the FDA of category A through D and then X of drugs. If you look at this is the way historically all drugs were coming to market, had to have kind of this label. So A means that we have good studies. They didn't show that there was a risk in the first trimester. And again, specified at the first trimester because that's the time of the highest risk. Then category B, which are probably, I was just looking through things as I was going through it, almost all of the drugs were class category B, is that we don't have great data. Animal data shows that it's probably okay. C is an interesting one. A lot of drugs are also classified there. That is basically animal studies showed some, but we don't have good data to prove that this harms in humans. So we sometimes use these drugs on a risk versus benefit kind of spectrum. And then category D even is there is risk, but you'll see that sometimes we use these drugs too if we have no other option. But and then X is we know it causes harm. Again, chemotherapy also it was category X, right? But in the right situation, sometimes it's going to have to be used. So this is the way I think we're all used to it. And then in 2015, all medicines were supposed to be changed over, actually, and supposed to happen by 2018, by June 29th. So the new expectation from the FDA for any new drugs coming to market is supposed to be going through pregnancy and lactation labeling final rule. So it's supposed to go, and I'll show you guys the format, and they're supposed to basically disclose all the studies and whether it's animal, human, or kind of whichever, and it's disclosing which data proves it. And they also provide you with a phone number or who to contact if you have been on that medicine or are planning to be on that medicine, because you're supposed to go into this drug registry so we can look at all the. This applies to all drugs that came to market after 2015. And after the presentation, I can show you guys kind of it's an FDA website, and you can see all the drugs that are on there. There's a lot of drugs on there. Unfortunately, I didn't see any antibiotics, but that's because that applies to things that came prior to 2001, June 29, 2001, and those are not subject to that rule. They are supposed to remove the category A through D, and are supposed to eventually transition, but they're kind of exempt. They're in this weird limbo system. So the way it's supposed to look, and I'll show you guys after, is basically they'll give you the registry, and they'll give you the risk. Right now, the letters are still there, but they're not supposed to be, just as a interesting aside, but they're there. And then they'll tell you the data that they're disclosing. Like if it was an animal models out of this many monkeys, rats, whatever they used, this was the effect that was seen. Or in human studies, this was what was seen. So they have to disclose the study. And then they mention the clinical context of when it may be used. Also, they added lactation, which is helpful to us because I think we sometimes get that question of, can I breastfeed with this medication? And again, the risks and the data. And then the new thing they added, kind of like I mentioned before, is for men and women of reproduction potential, kind of the risks and benefits and what should be assessed. I think that the other important thing to kind of note is that we all expect I know that when my wife was pregnant for the first time, I said, well, I expect my baby to be perfectly healthy, no problems, no complications throughout delivery, nothing will ever go wrong. And it never goes like that from the beginning, but we expect everything to be perfect. And looking at the data, so the CDC in Atlanta kind of keeps track of any malformations, major or minor. Is minor is a cleft palate, anything that they consider basically either genetic or minor or major structural defect. And if you look, the number is about 3%. So I think you have to keep that in mind, even with all the studies and everything we're doing. Sometimes, yes, we're going to blame the medicines, but some of that is, how much of that was really unavoidable is a genetic thing or something. All right, so come to case number 1. So a 22-year-old lady presented at 38 weeks gestation for routine follow-up. Her normal OB-GYN is out of town, so they get the cookbook of all the studies that they want to get. This is her first pregnancy. She's on the standard iron and folate. She's afebrile, asymptomatic, but her urine culture shows E. coli that is susceptible to Ampicillin, Nitrofurantoin, and Bactrim. So you're the person on call, and you can vote on your phone now, so I'll leave this up and we'll show the kind of number, what you guys voted. So you get called with this for essentially, a pregnant lady who doesn't have any urinary symptoms. So what would you do? Would you give her Bactrim, Nitrofurantoin, Ampicillin, monitor and treat if symptomatic? Call your ID pharmacist or call your attendant. All right, so we'll see. So most people said C. A few said B. All right, so yeah, so good. So everybody kind of went through a question. So pregnant women is one of the few causes that we treat asymptomatic bacteriuria. The reason it's important is because pregnant women, about 4 to 7% of them will have asymptomatic bacteriuria. It's associated with, it gave you a range between 20 to 40% increased risk of pyelonephritis, preterm labor, lower birth weights, and things like that. Some of the risk factors, which are interesting, were like lower socioeconomic status, diabetes, history of UTIs you kind of expect, increased age, and then increased parity and sexual activity. And most people kind of got that right. I think when I first looked at that question, I think nitrofurantoin, which we use all the time, I felt like when I was in OB, has a long history of use. But if you look at the FDA label, it actually says that in the first trimester, you can use it, but if there were no suitable alternatives, it's category B, which again, most of our drugs are. And it can be used in the first line in the second and third trimester, but there's been multiple studies. One of them was in Norway, which they looked at 180,000 births, and they saw that there was some less birth weights and some negative outcomes, nothing that was major, but that was a concern. And then a lot of some infants had more neonatal jaundice, which was clinically significant. And then some studies show that it can cause hemolytic anemia. So for that reason, actually, when you're close to term, you should try to avoid it if you're very close, because if you increase the bilirubin, there's a theoretical risk of cardictorus, so you want to avoid that. And then there was some other negative outcomes. So avoiding the first and near the end, which was interesting. Bactrim, I think we all knew to avoid in the first trimester because of folic acid inhibition and increased risk of neural tube defects. But also, you can actually use it in the second trimester if you want to, but you should also avoid it in the last part of pregnancy because it can also increase or high bilirubin. So you guys knew the correct answer, which was ampicillin. Ampicillin is safer. It has a higher risk of failure, as we know, where beta-lactams or penicillins are farther down the line to use for UTIs. So you actually should repeat a urine culture at about a week after. Somewhat controversial is also to obtain monthly urine cultures in these women. But those both are softer recommendations. There were like B recommendations from IDSA. All right, so kind of moving on to the next case. A 27-year-old lady presented to established care. She's 18 weeks pregnant and has newly diagnosed HIV on routine screening, which all of our pregnant ladies get, hepatitis, syphilis. She doesn't have any medical history, denies alcohol, tobacco, or drug use, no allergies. Her hepatitis surface B antibodies positive, antigen and core are negative, negative syphilis, negative urine culture, CD4 250, viral load 95,000, and negative HLA-B 571. So what would you do next for this person? Would you hold antiretrovirals until the baby is born and then start? Would you give no antiretrovirals but recommend a C-section and an AZT prior to delivery? Would you obtain genotype and then start abacavir, lamivudine, or raltegravir? Would you start abacavir, lamivudine, dolutegravir immediately? Would you give tenofovir, pirtobrutinib, raltegravir? Or would you give altegravir, cobicistat, pirtobrutinib, tenofovir? So let's see what most people. So most people said, oh no. Oh, sorry. Hold on, let me go. Sorry, guys. Forgot to put next question. My bad. Okay, just put your answer again. Sorry. We can watch this. Did it work? Keeps exiting out. It's an encounter problem. Okay, it should work now. There we go. Oh, so E is winning. I don't actually recall the answer. You guys want to see it again? Oh, it exited my PowerPoint trailer. I think I lost it. All right. All right, so most people said either E or F, which we'll talk about. Oh, my goodness. All right, so most people said either do tenofovir, tricytobine, raltegravir, or Genvoya, essentially. So, so the first line recommendations are basically you can choose either an abacavir, lamivudine backbone, abacavir, lamivudine, or tenofovir, and tricytobine, or you can even do tenofovir with lamivudine, plus either, more specifically, actually, the strongest recommendation is to do raltegravir, or you can do the 2-NRTI backbone with a PI. So the things that we do know is we should not use elotegravir or cobicistat, and that really comes from conceptually boosters in pregnancy, and that goes back to the concept of increased protein and then blood distribution. So boosters kind of work on the fact that you're going to boost these drug levels, but in pregnancy with more estrogen, albumin, and things like that, that doesn't necessarily hold true, and you'll actually have lower therapeutic levels. So that's important. Maraviroc and furotemide should not be used, and I think intuitively we think that since TAF came to market, has been a better medicine that we should, or safer medicine from a renal and bone perspective, we should use that, but there's not enough data, as well as dolutegravir. So we just don't have enough data, but you can use it, but still avoid it unless you had to, and then you should avoid H2 blockers and PPIs and these PI regimens, which was highlighted. The reason I brought that up too is because a lot of women are going to have reflux symptoms, and they're going to take PPIs sometimes, but more H2 blockers and calcium that will affect its absorption. The other things to avoid for sure, because we know that they have toxicity risk, are statavudine, diadenosine, and treatment dose ritonavir. And then I think a really important thing is, kind of been brought up, is if we should wait or not. Should you wait for resistance testing? Should you wait for follow-up? And really the recommendation is you should not, because your goal is to reduce the viral load as fast as possible and as effectively as you can, so that you can reduce the risk of transmission. So if you look at it, the longer you wait, the higher risk. So if you look at the trimesters, for preconception, if you're diagnosed, you only have a 0.2%, but then you go to 0.4, 0.9, 2.2 as you're kind of progressing through trimesters, because you have less time to get them virally suppressed, essentially. So your goal is to get them down as fast as you can. All right. So the next question, so 27-year-old with HIV, not compliant with ART, presents with headache. Oh, let me move the question.
So would it be
Oh, sorry.
Truvada Icentris?
Oh, sorry. Yes, it'd be Truvada centris. Is the best. It crashed again. And that's from AIDS info. But yeah, the best answer there would have been Truvada centris, yes. All right. I'll just abandon the voting, I guess. Yeah. So, and then the reason that's the best answer is because you don't want to use dolutegravir unless you had to. And then you cannot use Genvoya because of the cobicistat. You shouldn't hold ART. And then you don't need to wait for the resistance profile. All right, so 27-year-old HIV, non-compliant, presents with headache, photophobia, neck stiffness, and then is also found to be 11 weeks pregnant. Fever to 101, tachycardic to 110, BP 100 over 90, photophobia, CD4 of 20, viral load 100,000, normal FTs, bullets 152, and CSF with cryptococcal antigen positive with a high opening pressure. So, since it keeps crashing whenever I vote, so what do you guys think is the most appropriate treatment of this patient? So, fluconazole with flucytazine, amphotericin with flucytazine, fluconazole with flucytazine, amphotericin B alone, amphotericin with fluconazole or flucytazine. As Christina just presented like 4 days ago. What do you think, Christina? Yeah, so just amphotericin would be the best answer in this situation. So, cryptococcal meningitis, there is no real great data, no prospective data. Amphotericin is grade B, like we talked about, which is, maybe some in mice or animals, but nothing in humans. Conventional dosing and conventional amphotericin B is what's been most used, so that's what's recommended, which is just interesting. And then you would recommend that for 4 weeks of induction. Fluconazole, it was interesting because all the guidelines I was reading through initially, fluconazole was always a grade C and was actually upgraded to a grade D recently, so that's important to know. And I think that was one of the other big learning points that I got from as I was looking through a lot of these cases, is that all these recommendations for these drugs change rapidly, and you wouldn't even think to look, and it's already changed. And even as I was looking through the guidelines, it's only when I went to the FDA site that this was noted. So that's kind of important. And then you should never really use in the first trimester because that's where all the worst data is. And then flucytazine is grade C. And then another important thing, so whenever a woman is pregnant, kind of we'll talk about a little later too, but the immune system is kind of innately decreased, cellular immunity, because probably, so you don't reject the baby. So the other thing important to know is that after post-delivery, you should actually monitor for iris as well. And that's kind of important there. So the other question would come up, this lady's 18 weeks pregnant, you would give her 4 weeks of induction of amphotericin B. What would you guys do after that? Anybody? Amphotericin? Yeah, so I think amphotericin, you could do amphotericin, and another choice, an option through guidelines is you could, on a risk-benefit discussion, you talk about using fluconazole. The greatest risk is going to be in the first trimester, so you could use fluconazole theoretically. So I think that's kind of where things kind of get hazy is, they tell you this drug is category D. You should not use it because it could cause harm. But then if you look through the guidelines even and you go into the situations, they say, well, we have no choice really, so we have to use this drug because we don't have any other option really. So that's interesting as well. So next question is a 22-year-old G1, 12 weeks pregnant lady with HIV. She's not been on ART and presents shortness of breath. She has 2 to 3 months of progressive symptoms, non-productive cough, and worsening shortness of breath. She's tachypnic, has diffuse crackles, and is 84% in room air. Creatinine of 1, LFTs, bicarbonate 26. ABG shows PA of 2 of 60. Checks X-ray as diffuse infiltrate and sputum cytology is positive for PCP. So, you're consulted, what would you recommend? Would you recommend IV Bactrim and steroids, PO Bactrim, Tovaclone with steroids, Tovaclone, or just daylight tovaclone with steroids, BID tovaclone with steroids, Clinda with Primaquine, Primaquine and steroids, Dapsone, Trimethoprim, and Prednisone? Since my voting is not working, I guess I'll just with a ventured guess amongst friends. What do you think, Oasis? E. So basically the question is, in a PCP, severe PCP pneumonia, what should you treat a pregnant lady, even in the first trimester, really with? And per the AIDS info guidelines, the answer is actually Bactrim, which I was really, really surprised to actually see. Grade A3, because they said Bactrim it's that much better than all the other drugs that you should risk the patient not dying who's in severe with PCP pneumonia. That is the best choice. Even that you know that you have an increased risk of neurotubular defects, cardiovascular, and urinary tract abnormalities. And then they said you could consider giving a really high dose of folic acid to try to circumvent that. There was some small amount of data that said it could help, but nothing robust. But I think you're not going to cause folic acid toxicity. So you just give the folic acid in high doses. Steroids, of course, are indicated with somebody with severe PCP. Case control and systematic review shows that you have an increased risk of cleft palate. But again, it's really indicated. And then that didn't hold up in other large population data. Didn't hold through, but important to note. Dapsone does cross the placenta, can cause hemolytic anemia, and is a sulfa drug. And it can be used with Trimethoprim in the moderate to mild disease if you wanted to, but still, Bactrim is really the drug of choice. Pentamidine should not be used because it's embryotoxic. We don't have much data with the Tovaclone, so that's why that wasn't even as an alternative option in the guidelines. And then Primaquine is also we don't use that in pregnancy because it has a high risk of hemolysis, so it's also avoided. So the best answer in that situation would have been Bactrim, IV Bactrim. A 22-year-old lady, which is 8 weeks pregnant, immigrated from India, and then as part of if anybody else has immigrated, as part of the routine testing, get gifts of labs, many labs, one of which is quantiferon gold now probably, I think was PPD for me back then. But anyways, she gets reactive quantiferon gold. The rest of her labs are normal, creatinine, LFTs, etc. And then she presents to your clinic for evaluation of latent tuberculosis treatment. So what would you recommend? INH, INH with B6, rifapentine with INH because you want the shortest course you can give her because she's pregnant. Would you just defer treatment until days after delivery, defer treatment until 3 months after delivery, give her rifampin, or call Dr. Casañas, which is probably what would be the person you call first? The fastest answer would be call Dr. Casañas. What do you?
I am in a paper room and not picking up. What's your next choice?
I'll go down the line. What do you think, Mish? What would you do? Would you wait for a couple of days? Would you wait for a couple of months? 3 months. Okay. Yeah. So latent tuberculosis and pregnancy, the real kind of take-home point is kind of what Mish said. You defer treatment unless you really, really need to treat them for high risk. So the concept in that is that TB drugs are toxic I mean, hepatotoxic can cause liver injury. And in pregnancy, you are more predisposed to the hepatotoxicity for up to 3 months post-delivery. Again, probably just the catabolic state and the fact that all these chemical processes are going on. And the reason you would treat is if they have HIV would be an indication, if they need to be immunosuppressed, if they've had recent contact, it's also an indication to treat. And the reason that is because if you just had recent contact with somebody with tuberculosis, that's the highest time risk that you're going to get active tuberculosis. So that's what you're trying to prevent again. INH is the treatment of choice to give with B6. And it's important to note that it's excreted in breast milk, but not at high enough concentrations to either treat the baby, which is important if the baby is born with tuberculosis, but it's also relatively safe as much as you can say. But you can give it, but you should not really even says in the CDC guideline said do not discourage breastfeeding, which is also all right. So along the same lines, not the same 22-year-old, but we'll say 22-year-old lady presents with hemoptysis, night sweats, fevers, productive cough, Tmax 99, heart rate 108, blood pressure 104/76, crackles on exam, AFB positive, MTV PCR positive, CBC CMP normal, and you see a cavitary lesion. So if you have a 22-year-old lady with active tuberculosis. So what would you do now? Rifampin, INH, PZA, and ethambutol, RIPE. Rifampin, INH, ethambutol. Whole treatment, 2 to 3 months postpartum. Rifampin, INH, ethambutol, and streptomycin. Rifampin, INH, ethambutol. Or, which is cannot, I'll give you this. F cannot be a wrong answer. Or you call Dr. Kusanias. Yeah, we'll say in the U.S. We'll say this is a U.S. born. Yeah. Anthony, I'll defer to you since I'm going in my little circle. Okay, agreed. Yeah, so you want treatment because you have a high risk of morbidity, right? Which ones are you debating between? So, right? Yeah, so that's the question. That's right. So that's kind of the question. Are any of the components of RIPE teratogenic? And that is actually a complicated answer. So PZA is complicated. And the reason it is because WHO recommends it, but in the US, the CDC does not. So it really depends. That's why Dr. Montero actually asked, where are you treating this patient? Because in the United States, you don't want to use it. It's a grade C by the CDC. And looking even through the WHO and even the FDA, they said, well, there's not great data that it causes harm, it may cause harm, so we just don't use it. But the implication of that is that now you've bought this patient 9 months of treatment because you can't use the PZA. So that's conceptually important. Again, breastfeeding is not contraindicated. And it's interesting that it mentions don't discourage the patient from breastfeeding. So it's just interesting that's kind of the way they phrase it. Streptomycin had a noted 16% ototoxicity risk for the fetus, so that's why we don't do it. And then the correct answer, kind of like Anthony brought up, is you should treat because of higher morbidity. You can have a high risk of low birth weight, and the baby can be born with tuberculosis, which would also be less than ideal. But that's kind of basically they said that the risk of harm is greater than the risk of the medication side effect.
How would you test the newborn?
Oh, sure. So, and anybody. Yeah.
It's actually for a newborn, it's a placenta.
Oh.
Yes, it's a
Placenta is Dr.
The placenta to pathology, and they slice it up and test it at different places. Because the newborn, you have to aspirate first. If it's brand new, just started breathing, and you want to start therapy as soon as possible. The placenta is what you want.
So you test the placenta, and then importantly, kind of, whereas you can't use quantiferon in children. less than 4 because the IGRA is not specific for that.
I've come across 2 deliveries 15 years ago. Delivery, active TB.
Wow.
The bigger issue was baby and mom bonding, not being able to bond because of that issue as well.
Wow. I guess if the baby had tuberculosis, probably. Who knows? Yeah. There's no right answer. I don't think there's guidelines for that one.
Isolation.
Isolation, yeah. What were we going to say, Luis? All right, moving on from that. Next question is a 25-year-old lady, 22 weeks of gestation, presents because she needs to travel to Kenya next week for an emergency. Yeah. She has had a normal pregnancy with no problems. Her G6PD is normal. Her labs are normal. And she's referred to you, to Johanna, which is a perfect segue because Johanna has presented this. So which agent would you recommend for give a prophylaxis? Would you give atovaquone, proguanil, chloroquine, mefloquine, doxycycline, primaquine, or tell her, do not travel? So Johanna said mefloquine, which is the correct answer. So interestingly, in the CDC, before any drugs, the first thing it says is don't travel. That's the first thing it says. It says, tell them not to travel. But they're going to travel, so what's the next step? But that's the first recommendation, which is interesting. So the best drug is no drug. Mefloquine, its biggest downside is its neuropsychiatric side effects, but it's the safest medication to give during pregnancy for malaria prophylaxis. Atovaquone proguanil is category C, and like I said before, atovaquone, there's just not great data yet. Chloroquine, the reason you wouldn't want to use that is Kenya has higher incidence of chloroquine resistance, and then we don't want to use my favorite drug, which is doxycycline in pregnancy. And then primaquine, we talked about, you avoid because of high risk of hemolysis. So you correctly recommended the patient to take mefloquine, but she was concerned about the neuropsychiatric problems and that affected the baby, so she didn't take it. So now she presents with fever, chills, abdominal pains, hemoglobin of 7.6, platelets 105, LFTs 1.4, and 10% of her slides show this. Yeah. So what would you recommend for her to do? Would you recommend clindamycin and chloroquine? Treat her with mefloquine because she didn't take it. Call the malaria hotline, the CDC. There's a number. I'll show you that. Artesunate-based therapy, doxycycline with quinidine gluconate, artemer lumefantrine. Adam, I think you're the one up for that one.
Well, we established that you probably shouldn't use chloroquine.
Okay, fair.
Gosh, doxycycline, she's still pregnant, I'd probably avoid.
Okay, yeah, doxycycline you would want to avoid because of the pregnancy. Sure.
You down to calling the CDC, mefloquine, I like F, but I have no clue.
Okay, fair enough. So there is a CDC hotline. So looking all this up, the CDC hotline, they'll give you the number, available 24 hours a day. So very important, very easy to kind of look. And we'll talk about the answer in just a second. So malaria is more common. It can be more common in pregnant women. It also presents as more severe infections, probably based on the big concept of decreased immunity, cellular immunity specifically. Also, they think that women hyperventilate, so they think because of the CO2 production that it attracts more mosquitoes. And then I can't remember which country this was, but they basically looked at pregnant women versus not pregnant women, and the mosquito nets had way more mosquitoes trapped in the pregnant woman nets than the non-pregnant woman nets. But I don't know how robust, how well designed the study was, but just so you know. P. falciparum is is the most likely to be the one diagnosed here, right, because of the comma-shaped. And it's special because it can sequester in the intravenous space. They actually make specific antigens and antibodies, and they prefer the placenta. And the certain population that produces that antigen is the one that will be breed out. So that's important to know. And then pregnant women get more severe disease, and they're increased risk, again, conceptually in multiple different processes for severity of disease for 60 days post. Non-immune patients, so what I mean by that is that if you live in the United States and you traveled to a malaria endemic region, or you were in an area, even in the same country, that doesn't have a lot of malaria, and you go to an area with malaria, you're going to have a more severe disease because you don't have any baseline immunity, and then you haven't been exposed over and over, so you don't have antibodies. And HIV also has a worse outcome. It's associated with lower birth weights, high risk of miscarriage, preterm births. The recommendation, the first thing is you tell them, don't go there if you don't have to go there. I mean, that's, yeah. If you're native, there's, so again, this is kind of global health versus United States, kind of how we do things. So there are some recommendations to actually prophylax intermittently pregnant women in high to medium risk areas with, and you use the sulfadoxine-permethoprim, and you do that 3 times during the pregnancy. And then treatment in pregnancy really depends on the severity, and that's kind of where we'll come to the answer, kind of that question. So chloroquine and clindamycin is generally safe. If you have mild malaria, that's the first go-to regimen. Unfortunately, this patient had 10% parasitemia, signs of end organ damage, so have severe malaria. So for that, you would go to artemisinin-based regimens. Quinine can also be used. It causes more hypoglycemia. That used to be the treatment of choice before the new drugs. You want to avoid tetracyclines, doxycycline, permaquine, and a medication I've never heard of, which is nitrofurantoin. Again, severe malaria, basically end organ damage, more than 5%. If you need to use artemisinin, you need to call the CDC. Based on an IND protocol, they will ship you the medications. Call the CDC. You have to get that through the CDC. And then, yes. It's IV, so you can only go through the CD. So they'll like helicopter, or they'll like ship it to you. We had to use it once. Yeah, it's a mess. It's a mess. And if it's uncomplicated, yeah, it's very easy to get it, right? Actually.
Well, it was challenging. I think they really want to be convinced that the patient has a severe falciparum malaria to release the drug.
Right.
So you have to walk kind of those solutions, but they're very helpful in consulting.
And then the other 2 choices, the topical and proguanil and the artemisinin, are basically that's category C. So you only use them if you have no other option. All right. That was a lot of talking. So case 9. 28-year-old medical student is planning to become pregnant. She has completely no medical history, normal exam, but throughout her rotations, she got exposed to somebody with CMV at one time or another. So she wants your recommendation on how to proceed because she's planning to get pregnant and she knows too many things. The most dangerous thing is a transplant patient had CMV colitis, and she was examining the patient for the rotation. Wasn't in contact with blood, but was in the room with the patient with diarrhea. So what would you tell her to do? So would you treat with tenofovir? Would you treat it with tenofovir before pregnancy? Would you treat her with valganciclovir when she's pregnant? Would you treat her with ganciclovir when she's pregnant? Would you get a baseline IgG, IgM now? Would you give hyperimmune globulin once she's pregnant, or is there no therapy you can give? So that tough question comes to Louise. Yeah, pregnancy. And that's probably honestly the best answer out of kind of the options we have. Yeah. With confidence, but you have to say that with a lot of confidence. Yeah. So the women who are at greatest risk are women caring for really young children in daycares, or if you were, I guess, a hospital worker exposed to body fluids and things like that, what Dr. Sam was alluding to, CMV. And then the pregnant women who you should test are pregnant women, emphasize that, I should have put it in there, that have mono-like illness, or you get an ultrasound and it shows findings that are concerning, like calcification and things like that. Now, once you get, and you raise concern for this, you'll get the antibodies, which we'll talk about in a second, because that's a whole kind of bag of worms that you're going to open up. And the reason you get that is because your next step, depending on how you interpret that, is going to be an amniocentesis for the antibodies for the baby. And really, it's not because there's any therapy. Some people, there's some data that valganciclovir can cross the placenta because it concentrates there. But there is no data on any therapy. So I think that's important to just note as however you're pursuing this. Because really, you get an amniocentesis to see, is this baby going to have a torch? Are they going to have CMV and have other complicated problems? So really, supportive care. And then antiretrovirals could be used to decrease end organ damage to the patient specifically, not. And there's no data on how that reduces transmission. There was one study about hyperimmune globulin, which was published in JAMA, so I think it got people ramped up, but it wasn't proven in a different study. So there's no recommendation to really use that. Okay, so at the antibodies, you want to get IgM and IgG. And no matter how you really get them at first, if you're really concerned, where you're going to have to get next is get to a subspecialized lab. And it actually said in the guidelines, it recommended against getting it through like a commercial lab. You should get a specialized lab, because then you're going to look at the avidity of the IgG. And based on that, so if the case you would think you would be most concerned about is the positive IgM and a negative IgG, but then you have to look at the avidity of it. So if there's no, because that could be a false positive, so then you repeat it to see. And then if you have an IgM and IgG both positive, that avidity will kind of help differentiate those things for you. Again, really the best answer for that would be there's no great data of what to do. And then Garo stepped away from his question, so I guess we'll move back there. But a 22-year-old lady, 24 weeks pregnant, presents to you with positive RPR. She reports 2 male partners, 1 recently treated for syphilis. She was given ceftriaxone. She says that she's had ceftriaxone in the past as part of her STD treatment, but also got penicillin and had anaphylaxis. So she really, really doesn't want to try the penicillin, but she wants it. But she could. So, Shyla, what do you think? What would you do for this lady? Would you treat her with penicillin, treat her with ceftriaxone, give her doxy, treat her with azithral, or call Dr. Tony and do that? Right. So no matter what, no matter how much they want to convince you, still, like you learn in medical school, and the whole time you give them penicillin, no matter what, essentially. There is some data. I was trying to look. There have been studies in Germany and somewhere in, I can't remember which country. It was in Asia, that they're trying to use some ceftriaxone, but there wasn't great data either way. And then an RPR may not appropriately decrease, but it depends on multiple factors and which stressor. So it's really going to be hard if you need a repeat to determine which way. But you should really, really always give them penicillin. And Dr. Berger, the reason I wanted to bring up, so he is one of my mentors from UK. And what he said during a morning report a couple of times is that basically the worst thing that can happen to you as a physician is that you could do the wrong thing and good things happen. So in that situation, you know, where we're trying to, we know we're having worse data with ceftriaxone, and the patient's kind of trying to twist your arm because they're declining to use it, you could potentially get away with it once, but the thing that can happen is eventually, just by stats, you'll eventually get burned on that. And then case 10 is a 26-year-old lady, 36 weeks pregnant, came to ED with fever, photophobia, neck stiffness. ED puts her on antibiotics, gets an LP. They put her on Vanc, Ampicillin, ceftriaxone, and cyclovir. You're called, Mindy, because you see this on the gram stain. So, based on that gram stain, how would you change your antibiotics? Or would you give her Vanc, ceftriaxone, Ampicillin, Vanc, Mirum, Ampicillin alone, Ampicillin plus gentamicin, vancomycin, and Rocephin, vancomycin, and Cephin? What do you think of the diagnosis? It's a rod, gram-positive rod. It was rod. Gram-variable, actually. Gram-variable rod would be what you would. Listeria, right. So you think Listeria because the decreased cellular immunity for meningitis. See, ampicillin. So ampicillin alone, I think, is definitely part of the gamut. And looking through it, it's not as hard and firm recommendations, really. So pregnant women are more predisposed to Listeria because of decreased cellular immunity. You can get GI symptoms and things like that. They're more likely to get a bacteremia, for which you would always use ampicillin. But some of the things I was looking at is ampicillin gentamicin is preferred. But all the data for the gentamicin is only in vitro data. There's no in vivo data, really. But in meningitis, you consider that. And then just as a side note, most of these infections occur in the third trimester. Bactrim, Vanc, and Meropenem are all alternatives to use for Listeria. And then basically, my conclusion for this talk was academic integrity. Really what I meant by that is that everything changes all the time. Even fluconazole changed in the you know, you read one guideline and you kind of look something else up. So I think whenever you approach these patients, you're going to have to look up at the current category, especially with the labeling system, of what's really going on. You're going to have to look that up because the data truly is evolving. And for a lot of these drugs, there's not great recommendations because there's not great data. It's kind of the things we've done and we think are doing okay. And with that, these are my references. Really good information to look things up were through the CDC and AIDS info. I think were the most helpful, but kind of other things. With that, I'll take questions.